Welcome everyone to the monthly NCIRS seminar series. I'm Frank Beard, a public health physician working at NCIRS. I'll be chairing the session today. So first of all, I'd like to acknowledge the traditional custodians of the land on which we're meeting here today, the Darug people, and pay my respects to elders past, present and future, and to any Aboriginal and Torres Strait Island people who are here physically today or online through the webinar. Our note to our webinar audience, so you only have a view of the slides today and hear the audio, not the presenters. And as usual, we'll take selected questions from you. You can do that via the Q&A tab on the website, but please submit those questions during the presentation. Today we've got two halves. So the first half hour will be on influenza. So with the flu vaccine program rolling out next month, we thought it was opportune to look at the vaccines that will be available, recommended and funded. And then the second half will be on MumBubVax, which is a new tool to facilitate conversations with pregnant women about influenza and pertussis vaccination. And that's based on research from Sharing Knowledge About Immunisation package, which was the topic of last month's very popular NCIRS seminar. So straight into the first section on influenza. So our presenter is Christine McCartney, who's the director of NCIRS, a paediatrician and infectious disease specialist, and people who've attended these webinars and presentations, seminars before will have known Christine because she's usually introducing the seminars. So I'll hand over to Christine.
Okay, thanks very much, Frank, and thanks everyone for joining remotely, however many hundreds of you have already dialed in, and to all of our audience here in the room. So it's my great privilege to be followed by Margie and Jess, so I've got to make sure that I don't get too bound up with talking to you for too long about flu, which of course I could do forever. But the flu season is ahead. It's still hot out there, at least in Western Sydney, but we know it's coming up. So the aim of today is really to give you a bit of a heads up about the changes that are coming with this year's program, to look back a little bit and just recap on some of the vaccine effectiveness, safety and other data from last year and indeed from 2017 as well. Think about what this means for clinical practice for all of us coming up. And I'm going to have a consistent and really annoying theme throughout this talk, which is we must get these vaccines onto the Australian Immunisation Register. It's not always 100% easy, but there is a direct imperative to do so. So the outline is a little bit matched to the learning objectives, and there's someone sick there from flu, which none of us want to be. So this slide's courtesy of my good colleague Alan Cheng, particularly with respect to underdiagnosis and overdiagnosis, but we all know there's a burden of disease from influenza, and what an amazing virus it is, right? So you can be a perfectly healthy person, you can have an asymptomatic infection. Well, it's actually not an illness if it's asymptomatic, so I'm going to tell Alan that. But you can have an asymptomatic infection down here in the bottom from the same virus as a healthy person, or you can die from that virus as a healthy person. And we really don't understand why, but we do know that this spectrum of disease is very broad. And what's important is that we have fantastic surveillance systems here in Australia. We have a number of systems that work together. But in all of them, again, when we do sample people who have either been hospitalised, have been in ICU, or attended a GP with influenza-like illness, we really want to know if they've been vaccinated or not. So first of the plugs for recording vaccination. Likewise, with all these systems, they come together in an annual end-of-year influenza report, which is available online. So I've got the URL there for you. There's quite a bit of information in this report, and it gives us a good recap of what happened in 2018. And there are actually some jurisdictions that produce their own reports in this regard as well. So what was 2018 like? Well, we had a number of new vaccines, as you'll no doubt remember. For the over 65s, we had 2 enhanced vaccines. They were trivalent vaccines, so the adjuvanted influenza vaccine, as well as the high-dose trivalent influenza vaccine. And then we had all the new jurisdictional programs for children aged 6 months to less than 5 years with our QIV. And everybody will remember we had some supply issues. So I think a lot's been done to be looking at that very closely within the jurisdictions for this year, and hopefully we won't be seeing that this year. But here we had a whole new target age group, essentially across the entirety of the country, being all 6 months to 5-year-olds. How did we do? I'm going to give you a little bit of data. I can't tell you everything because we actually have a publication coming out on this next month with the MJA, led by the good Dr. Frank Beard. But I can tell you that our uptake in Indigenous children doubled across the country, and there was a 5-fold increase in all children. So you're going to say to me, oh, she's not telling me very much. There are no numbers. So I will tell you some numbers. Basically, this is coverage as recorded on the Australian Immunisation Register, and it's probably not as complete as True Vaccines and Arms. So again, even with children who we know that register is very reliable, we still think there's a degree of underreporting. But nonetheless, we saw across the country Indigenous uptake go to 30% from 15%. In the Northern Territory, this was more than 60%. So they're doing amazingly well in the Northern Territory. So bear that figure in mind, because what we really want to think is what's our aspiration? What would we really like to achieve? I think we can go higher in Indigenous children. And in all children across the board, we went from the very low starting point, 5%, up to 25%. Now, that still means that only about 3 out of 10 children are being covered with these programs. And there have been evaluations of some of these programs across the board. We know that they got up and had to be delivered very quickly. So again, I think there's a lot of lessons to be learnt from last year in respect to how we approach this year. The uptake was highest in the young. There were variations by jurisdiction, and some more of the details going to be, in press in this article. Can I tell you what coverage was in the older age groups and older children and in adults? No, because a minority of the doses that were distributed across the whole country were actually entered onto the air. Less than half. Okay, so we have built a fantastic new resource and we need to start using it. Now, this was a fantastic just snapshot of some work being done by Sammy Carlson, who I think is here in the audience with us today, one of our PhD students. And there are a number of people around the country looking at influenza in children and the attitudes of parents. But Sammy's work is unique in actually interviewing parents and families of children who've been hospitalised with the flu, and most of them have not had the vaccine. So we're trying to unpick then, whether you're healthy or not healthy, why you mightn't have had the vaccine. Sammy's using the COM-B model, again supported by Julie Leask in her PhD, and there's a whole bunch of different factors here, whether it's limited capability, missing motivation, lack of opportunity, sometimes missing recommendations, unusual recommendations coming from the primary care sector sometimes about don't be vaccinated, even though we've got a funded program. So a lot of things that might work together to actually not have the flu vaccine received. So there's a lot more data coming in regard to Sammy's work. And I've put this slide in to remind myself that A, kids are very cute, we all know that, but B, I can't talk more about paediatric influenza because in fact there's 3 fantastic presenters next month who are going to talk even more about paediatric influenza because it is such a hot topic at the moment. Okay, so was the vaccine effective last year? Yes, it was actually quite effective as far as we know flu vaccines go. So the season was overall an H1N1 dominant season. The vaccine effectiveness was around the 55.5% mark against hospitalised disease, slightly higher against GP visits. So that's using the aspirin network, the test negative design and the aspirin network as well. And look at this, it was pretty similar in the elderly as compared with the non-elderly adults. So I often ask myself, where do I fit in that equation? But let's put that aside. And there was no statistically significant difference by vaccine type in the over 65s. So this was using the FluCan method of assessment. So that's looking at hospitalised, test negative and test positive adults, whether they've been vaccinated or not vaccinated. Rather limited sort of data set when you come down to looking at differences between brands. So there were rather wide confidence intervals there. But if you look here, you can see the way that things stratified out. And I talked about the VE, or I haven't talked yet, about the VE being higher in children. So you can see here the outlier in the good way is actually that vaccine effectiveness in children. Now, there are overlapping confidence intervals, but don't let anybody fool you and tell you that the vaccine does not work in children, including very young children. It works as well, or last year even better than in adults. So we all remember that we did a lot last year because 2017 was such a large season. 2018, and I think you've already seen this or you know it because you lived through it, we had low activity overall. And we had a predominantly H1N1 season, and we had this good vaccine effectiveness that I talked about. So here's what the epi curve with respect to ILI presentations to sentinel GPs looked like. It was the low red bar here for 2018. Look at the 5-year average, which is the one in the middle. I'm just pointing to the blue dotted line for the audience in the room. And look at the 2009 pandemic, where we had a lot of presentations to GPs. It's a little bit different when I show you the hospital or the notification data rather in the meantime. So this is in the next slide. This is the next slide with the notification data. And you're going to say to me that this was 2009, but it indeed was not. This was 2009, the grey line. So here we've got laboratory notifications to the NNDSS. The blue line was actually 2017. And there's a lot of reasons for that. We talked about this last year. A lot of it is a lot more testing. We had a lot of H3N2. We had a big burden in the elderly, but, you know, a remarkable number of notifications. Which one was 2018? This little green line here. So it was a nice year to have, really, with respect to flu, except for a bit of a sting in the tail, which I'll get to in a minute. That sting in the tail was the interseasonal peak that we've been seeing in the last few months. So many people would be aware of this. It hit the press in the Northern Territory and in Queensland around sort of November, December. And it's been prominent, I think, in the media even in the last few days, including, sadly, a death in a young child in Victoria in the past week. So we have seen unusually high interseasonal activity. Spreading around different parts of the country, around 2 to 5 times the actual numbers of cases that we would normally see in these summer months, and mostly H1N1, although in some parts of the country it's been about 50-50 H1 and H3. Here's an extract which shows quite graphically from Queensland, the sting in the tail at the end of last year. This is available online. And you're welcome to ask me at the end why this is. I'm not sure that I can really tell you. You could also ask me, were these people vaccinated? But I can't tell you that because we didn't have the data in the air. So that's the 5th time I've said that, and I'm going to say it another 5 times before the talk is over. We've got to get that data recorded so we can understand these sort of questions. Was the vaccine safe last year? The short answer is yes, all of the vaccines were safe. So we have a nationwide 270 site active surveillance system in this country for vaccine safety. It's fantastic, and I'm not biased because we administer it out of here, but we have these wonderful collaborators, SmartVax and VaxTracker. We have more than 1 million entries, for example, in SmartVax, and 70% of people who get sent that SMS after receiving their routine vaccine reply, tell us how they went, and we can see that data by brand. So we published the 2017 data. This publication is courtesy of Alexis Pillsbury, open access online. And the 2018 data, we had respondents totalling more than 165,000. So this is 165,000 Australians who've fed back how they went after their vaccine via a short SMS survey. And you can see the overall number, or percentage rather, responding that they had any sort of adverse event that they perceived to be from the vaccine was very low across the board, whether you are 6 months old, pregnant, or over 65. And this green, even lower amount here, is the number who said that they went and they sought medical care within 3 days. Now, it doesn't mean it was definitely from a reaction to the vaccine, but it was something they perceived could be related to the vaccine. It might have been a viral illness, but very low proportions, very consistent across multiple years. And I will show you in the next slide that there was not really any difference with respect to brands. So I've focused in here on the 2 new brands. This is the FluAd and the FluZone, the enhanced vaccines in people over 65, slightly higher injection site reactions and slightly higher fever with the high dose as opposed to the adjuvanted. But that's much of a muchness as far as, you know, I'm concerned, and really everybody's concerned, well within what we'd expect, and no difference in the number of people seeking medical attention. So both of those brands last year in older people, more than 50,000 were very safe. Okay, so now what's coming up? The flu season is approaching, but before the flu season is the flu vaccination season. So don't get the two confused. First, we have to vaccinate everybody, and then we're going to prevent flu from happening. There are 2 changes to the vaccine this year with respect to actually both the quadrivalent or the trivalent. The AH3N2 is changing, and then the B strain that is common to both the quadrivalent and the trivalent. It's good news that the H3N2 strain is changing, because we have seen a difference, so a move away from the relatedness of what's been circulating in the community with respect to the AH3N2 and the strain that is antigenic in the vaccine. And that's for all sorts of reasons, including adaptation of the vaccine strain in eggs. But this rather complicated graph, which again I've pinched courtesy of Alan Cheng, I won't explain, but it can show you that on this genetic map we had differences here, and this change is trying to rectify those differences. This is a great news story. We are finally funding influenza vaccine across the board, free for all of our First Peoples, all Aboriginal and Torres Strait Islander people now eligible to receive the vaccine for free. So I took this picture of lovely Millie and her family off the ABC website. It's a celebration of Indigenous families and culture. But if she was going into the clinic last year, she couldn't have got her children in the 5 to 14-year-old age group vaccinated. This year she can. The whole family can be vaccinated for free. This is a shout out in the corner to Katrina Clark, our National Indigenous Immunisation Coordinator, who I think is here in the room, and who gave a really impassioned speech advocating for this change last year. Many others who've worked hard to get this to happen, including deriving the evidence on the increased risk, which is about twofold for Indigenous Australians as compared with other Australians for being hospitalised from the flu. So the take-home message here is really promote this amongst our Indigenous Australians. It's going to keep all in the community healthy and strong if we can vaccinate as many Aboriginal and Torres Strait Islander people as we can. The children's programs are continuing. This is my slide from last year, or somebody's slide from last year. So they're, as far as we know, unless any state or territory wants to send us a quick email, they're all continuing. It's the Northern Territory that is the one state that is not offering immunisation to non-Indigenous children, but they do have the high coverage in Indigenous kids. So this is perhaps what you've been waiting for the most. This is the busy table with the multiple brands, the different ages, which vaccines registered in which age group, and which vaccines NIP funded. So this is something to think about every single time you go to the fridge. And you don't have to digest it all now in one slide. I'm going to take you through what the changes are to try and make sense of it. Okay, so what's new for children and adolescents? We know the programs are still existing, funded for the under fives, but what are the vaccines going to be? Well, there are some changes. Firstly, flu quadri, still in the what we call half dose, so 0.25 ml for 6 months to less than 3 years. That's the one you pull out of the fridge if you're looking at flu quadri. For that age group, it's got to say flu quadri junior, and 0.5 ml for 3+ years. So that's not different to last year. What is different this year is that Fluorix Tetra is now registered right down to the age of 6 months, but in the same volume as it is for those over 3 years. So for 6 months to 3 years, it is still the full volume, 0.5 ml. It will say clearly on the box. So in essence, depending on which brand you pull out, you're either going to be using 0.25 ml or 0.5 ml, but dependent on the brand. So that's a very important thing for vaccinating those young kids. And of course, we all know if they're being vaccinated for the first time ever, they need 2 doses a month apart. What about Afluria Quad? Well, this vaccine last year was only registered down to age 18, so in 18 and above. This year, it's registered from 5 and up. So that's quite a big change. It's now available as another quadrivalent vaccine from 5 years plus. And I've put a little footnote here. It hasn't come up yet. Now it's come up. To say there is data in the case of inadvertent administration. So I'm rather reluctant to say this, but just bear with me here. If someone's accidentally given this vaccine, Afluria Quad, to someone under 5, don't panic is the take-home message, because there is quite good comprehensive safety data in the under 5s. It's not registered or recommended, or certainly not recommended for that age group at the moment, but it is registered in that age group in the US. So things have moved on from where we were with respect to the same manufacturer's brand from a while ago. And there is this multi-year safety data now in that age group. Check vaccine, brand, check age is the take-home message for children. Okay, what about for the 65 plus? Well, you can see here that there's a lot of vaccines registered in this age group we knew from before, but there are 2 that are not NIP funded. So remembering that every single person who is 65 years or more can get free vaccine. They shouldn't really be paying at the chemist. Their vaccine's free for them. They should be choosing one of these NIP funded brands or having that selected for them from whichever provider they're going to. On the NIP then, there's only one of the 2 enhanced trivalent vaccines that is available NIP funded. It is the adjuvanted TIV called Fluad by NCIRS. And Fluad does remain recommended in preference to the QIV in the 65 plus years, same as last year. That doesn't mean it's a bad thing to give QIV, it just means it's preferred over the QIV. There's no preference between Fluad and Fluzone high dose, as was the case last year, but Fluzone high dose is not NIP funded. So that's pretty straightforward, I hope, as a message for people. We've got pretty good coverage, we think, in the over 65s, but remember, you know, don't miss the opportunity to vaccinate. We know we've got to get the season off and going really quickly. I'm not going to say too much about pregnant women because our ladies to talk about pregnancy are here, but 2 quick messages. Even though she looks a bit worried about getting a vaccine, why is she vaccinating? She's vaccinating. One of the main reasons we know is because she knows it's going to protect her baby to get the flu vaccine on board, just like it does for pertussis vaccine, helps protect your baby. And we can only give vaccine from 6 months in babies. And the other reason is because flu vaccine is safe in pregnancy. So they're 2 really key take-home messages that I think we'll hear a lot more about how to support pregnant women in detail about that. Again, another PhD student here, Jocelyn McRae, again working on the same partnership grant that we have across the PEDS system, looking at paediatric influenza. Jocelyn has been examining the effect of maternal vaccination on preventing hospitalised proven influenza in very young babies. And essentially, this wasn't a statistically significant estimate, but the trend is really there that we see in the first months of life, flu vaccine being very protective if mum had it for keeping her baby out of hospital with the flu. So again, there's more data coming for this, and a shout out to all the fantastic PEDS nurses working across the country who are gathering this data. Okay, so last few more slides are some quick questions. Why should I make sure my patient's vaccine is entered onto the air? Well, it's a no-brainer, right? Safety and quality. You need to be recording that vaccine in your practice, wherever it is, into the appropriate space in the patient record, and that is on the Australian Immunisation Register as well. So this will help us inform vaccine supply and you know, respond to the demand for vaccine. If we know where the vaccine's going, when it's going, it will help us. It will also help us assess individual outcomes. So when your patient's admitted to hospital and they might have something wrong with them, and we try and work out whether they got the flu vaccine this year, somebody in the hospital can look it up, or vice versa. And it's going to allow us to assess program impacts better. So we all probably know this in this room, but, you know, it's just really important to emphasise that it is the right thing to do. We now have a whole of life register. Let's use it. Whoops, and I've moved quickly to the second slide, but the second slide is saying, how do we report influenza vaccine encounters to the air? And this is especially a shout out now here to Lauren Dalton and Cheryl Jones, who've been working with the PHN Immunisation Education Program, doing a lot of liaison between the Department of Human Services, who've also been doing a lot of work in expanding the air. But it is really important that to know for everyone that it can be the practice management software, particularly obviously employed by GPs, to be important to ensure that that software is up to date, to be and connecting and transmitting, and then that step is occurring for transmission up to the air, or data can be entered directly via the air site. So commercial providers, so I'm talking here about all the big companies that go out and vaccinate everybody who works for, you know, a big company, and pharmacies, they can also send encounters to the air, and they can do that by registering as a vaccine provider via the DHS website. So if you're working, say, as an immunisation nurse in a great big company that's going in and vaccinating 10,000 employees in some even bigger company, make sure that the company you're working for is hooked up and sending that data to the Australian Immunisation Register. They can do it by talking to the DHS. Okay, so what materials have come or coming? We've got a letter from our Chief Medical Officer, Professor Brendan Murphy. It's the brief version first, and there's more detailed materials coming. Only New South Wales has got their, 5 minutes. Only New South Wales has got their data up at the moment, unless any other states or territories want to send a message to tell us that they've put something up in the last 24 hours. And NCIRS fact sheet is going up. I've got the signal. It's going up today. It's up already. Yay! So there is a lot of this information that I've been talking about in the fact sheet, and of course this talk will go up as well. When's the vaccine coming? Some multi-million-dollar questions. So some of us in the room may remember the old days when vaccine was in the fridge sometimes in February. We started in March. Not the case anymore. Vaccine will be in the fridge soon. Really mid-April is what we're talking about as a date. Unfortunately, we are in this uncomfortable little hiatus period now where we don't have vaccine in the fridge. That is, within end expiry date. We've got the new vaccine coming very soon. The official season start date is 1 May. And as the Chief Medical Officer says in his letter, as influenza usually occurs in June with the peak around August, vaccinating from mid-April will allow people to develop immunity before transmission is at its peak. There are now a number of studies, and I think we talked about these last year, that do show waning effectiveness of the vaccine over the months after vaccination. It's not a, all perfect then drop off a cliff. It's a gradual waning over those months after immunisation. So the new timing of the program, the new timing of vaccination is really tailored now to address this waning and try and provide maximal protection. And are vaccines safe? Follow us online for the weekly reports of, what'll be a couple of 100,000 people telling how they go with the vaccine. These are the reports from last year, broken down by age. So follow us online at AusVac Safety, and happy influenza vaccination season.
Great, thanks Christina. Great presentation covering a huge amount of stuff. So we've got 5 minutes time for questions. Do we have some from the online audience to start with first? We've got a couple.
So the first one is about if you're a pregnant woman and you had the vaccine in mid-April and you were not pregnant at that time, you then become pregnant in May, should you get another flu vaccine in June or July of that year?
Okay, so you just conceived somewhere right around the time when you got your flu vaccine or shortly afterwards. Yeah, so I think I feel like I need one of those pregnancy wheels that I used to have back in the day when I was pregnant, and you could dial up. Margie may wish to answer this too. We don't recommend routinely having 2 vaccines in the same season, closely spaced, I guess is one of the things. Does it harm you? Does it hurt you? Probably not. We do for some groups, such as those undergoing transplantation and the post-transplant, they can have 2 vaccines in the same year. We do give 2 vaccines in a row to young children the first time round. If that pregnant person felt that they were going to continue to be at risk further along into the pregnancy, they could consider later in the year having a second vaccine. There's probably no harm in doing that. But, if they're in the very temperate part of the country and they're very unlikely to meet flu and they're not going off on a trip to the Northern Hemisphere, they probably don't need the second vaccine. I think it's optional. And I think the other thing you have to think about is, well, what gestational age would they be the following year when the following year's vaccine's out? And they probably would be pretty close to delivering. So maybe there would be, in that context, I'm trying to add up all my weeks. You're going faster than I am, Margie. And think, well, you could still do that, because you still might build your immunity prior to delivery of bub. So, it's an option.
And the second one was, what are the barriers to collecting vaccine effectiveness data for at-risk groups and for other groups like Aboriginal and Torres Strait Islander people?
So there is a major barrier to collecting at-risk, understanding who's at risk, who's been vaccinated, and that relates to the fact that, as we know, and as is appropriate and legislated, there is minimal data collected as part of the fields on the Australian Immunisation Register. So it's essentially, date of birth, place where you live, so your age, what vaccines you've been given, and then your Aboriginality, yes or no. But there is nothing that is on the air about whether you were pregnant. There's nothing that's on there. Pregnancy is not recorded, and nothing about whether you have underlying risk factors, and nothing that is different about what vaccine you get if you're in those categories. So at a really big data level, the best way to address those questions are to link the fantastic individual still unfortunately siloed large data sets that we have in this country. We're very lucky to have them, and as soon as we can link to the AIR, we'll be able to do a range of fantastic studies that look at vaccine effectiveness, including in people with risk factors, particularly in people with risk factors. But to do that, we need to have the data in the air. So first off, that is where it's got to go, and then we can do the linkage. There are smaller studies, obviously, that do focus. FluCan and PEDS both look at effectiveness in children with and without medical risk factors, and that's actually usually similar, not a big difference in risk factors.
Okay, time for a couple of questions from the room now. Holly?
I was just wondering whether there have been any resources developed that can help providers answer questions like you just had before about either, should I receive 2 vaccines in one season? Should I delay getting vaccinated, which is a question that often comes up. About the preferences between the 2 vaccines. Is there any kind of Q&A resources available?
Well, as I've mentioned, there's...
Summarise the question.
Oh, summarise the question. Are there resources available, or soon to be available, I might add, with some of these more clinical practice points, frequently asked questions? So we do try and address some of these in our own FAQs. Some of these come down to individual clinician-patient choices and preferences. There are the high-level recommendations that I put forward. So you saw the preferences, say, for vaccine, NIP-funded vaccine in the over 65s. And then some of these more subtle things definitely are, they're not all predictable. Now, some of them we try and address in our own fact sheets. Definitely some of the states and territories will have answers to those questions. I think we all welcome feedback on our resources, and there are always a few new questions that come every year. We'll try and be very responsive in our own fact sheets in that regard.
Okay, thanks. I think we might need to move on now. So thanks, Christine. So so we're moving on to the second half, which is MumBubVax. So we have 2 presenters first. So Dr. Margie Danchin, who's a paediatrician at the Royal Children's Hospital in Melbourne and works also at the Murdoch Children's Research Institute, and Jessica Kaufman, who is a postdoctoral research fellow working with Margie at NCIRS. So,
thanks, Frank. Thanks very much to Christine and the NCIRS team for having us. And so, yes, Jess and I today are going to present an exciting new intervention that's been in development for the last year or so called the MumBubVax intervention. But before I proceed, I just really want to acknowledge Julie Leask and the Sky team, as well as Nina Berry and Pen Robinson. This work is very much built on the Sky work that was presented last month at the last NCIRS webinar. So, essentially what we're talking about is the promotion of both maternal and childhood vaccine uptake. Christine's talked a little bit about influenza vaccine in pregnancy, but clearly pregnant women and infants are a WHO high-risk group at increased risk of hospitalisation for flu. They have double the hospitalisation risk and for complications, particularly premature delivery, and also death from influenza, and particularly infants in the first 6 months of life are very high risk from influenza illness and death. Now, pertussis is less of a risk to the pregnant woman herself, but is life-threatening for infants under the age of 6 months, and particularly for infants under the age of 3 months. So it's very clear that we need to sustain acceptance and uptake of antenatal vaccination for both flu and pertussis. And we have come a bit of a way in terms of vaccine uptake, particularly for flu. About 2 years ago, it was sitting around 30%. Now we estimate that flu vaccine uptake in pregnancy is, some recent data from South Australia in disadvantaged population is around 35%, and some recent data from Victoria that Stacey Rowe presented at ESPID last year was around 40%. So we've still got a long way to go. Some data that Annette Reagan published recently was up to 60% in WA. But as you can see, sitting somewhere between 35 and 60%, we have a long way to go, particularly for flu vaccine uptake for pregnant women. Pertussis is a bit higher since the national recommendations that came in 2015. And that sits somewhere between 65 and 80%. Again, it's very difficult to get national data and data that is accurate across all jurisdictions and populations, but definitely the uptake of pertussis vaccine is higher than for flu. But together, some recent work has estimated that most women, probably only about 30% of women, receive both vaccines. So essentially there's a need not only to increase the uptake of current flu and pertussis vaccines, and just to reiterate that flu vaccine is recommended at any time in pregnancy, and pertussis at the moment between 28 and 32 weeks, but we think that that recommendation will probably come down quite quickly to about 20 weeks. But there are other maternal vaccines in the pipeline, particularly RSV and Group B strep, that could become available, particularly for RSV, even in the next couple of years. We also know that pregnancy is a key vaccine decision-making time point when parents not only have to, or mothers not only have to make a decision about maternal vaccination, but when they really start thinking about childhood vaccines. And this is particularly true for mums in their first pregnancy, when we know that they're much more likely to be more highly vaccine hesitant than mothers who have already had children. That decision obviously starts with the birth Hep B vaccine, and that's not accurately recorded, but from some data that we have, we know it's probably only around sort of 80 to 85%. So, and also other work that we've done has really clearly highlighted that in the public antenatal system, where about 3/4 of antenatal care is delivered, midwives are the key provider that mothers access for vaccine information, and they are highly trusted. Now, that might of course be because in a low-risk pregnancy, many women may only access an obstetrician a couple of times, and the work that we've done has not specifically targeted GP-led care or private obstetric practices. So a lot of the work that we're talking about is very much targeted to the public antenatal setting. But it's very clear that in addition to increasing uptake for these vaccines, we also want to try and improve expectant parents and pregnant women's confidence in vaccines, and their decision-making confidence also in childhood vaccination. So essentially, when we sort of define the problem, particularly around maternal vaccination and flu vaccine in particular, there's a need for effective and scalable interventions that actually embed antenatal vaccine discussions into routine care and can also be linked to improving childhood vaccination. And that's really what we're going to be presenting today. And this intervention package is very much designed around improving vaccine conversations between pregnant women and midwives. So what has already been done in terms of improving flu vaccine uptake for pregnant women? I'm going to present some data from a recent systematic review that's just actually been published in the last month that looks at about 26 interventions and looks carefully at what are the most effective interventions at improving flu vaccine uptake for pregnant women. Not surprisingly, interventions that primarily aim to change vaccine attitudes for the pregnant women or the expectant parents themselves are generally not effective in isolation, except where they are more effective if the content particularly reinforces the benefit for the infant. And we see that a lot around pertussis vaccination messaging as well. What we do know is that the strongest predictor of vaccine receipt for a pregnant woman is a provider recommendation. And so surprisingly, there are actually very few interventions that have been developed that focus on the provider-patient interaction and on communication training for providers. We know, and it's been published extensively, that providers find this difficult. It's hard to talk with a pregnant woman who is hesitant about vaccination and to have the tools and the skills to be able to have that conversation and provide the information that they are seeking. What has been shown is that nudge-based interventions actually have the highest rate of success. So what do we mean by that? That's particularly around provider prompts to vaccinate a pregnant woman or record vaccination, or patient prompts in the form of text messages for pregnant women, or standing orders. So for example, in private obstetric practices in the US, up to 2/3 of practices actually have standing orders. But there are still significant barriers to the use use of standing orders, primarily around the provider wanting to have some engagement with the patient about making the recommendation, but also around those vaccinating, not feeling like they have the skills to be able to address the pregnant woman's questions. And of course, availability of vaccine on site is a barrier as well. For example, in Victoria, the Royal Women's Hospital, which is our largest maternity service provider, does still not provide vaccines on site. So standing orders are effective when they're able to be implemented, and in fact they've been shown on their own to increase uptake by up to 24%. But really the nudge-based interventions are aiming to build on the positive intentions to vaccinate and really kind of bypassing that vaccine attitude loop, if you like. But what we do understand is that if we just use nudge-based interventions, how do we increase confidence and sustained confidence in vaccination over time, particularly in the face of any vaccine safety scares? And I've talked about the barriers of provision of vaccines on site. So what our intervention is really based in is this model called the P3 model, which is a theory-based model of preventative healthcare behaviour that looks at interventions at the practice and the provider and the patient levels. So this model is really a way to design and develop preventative healthcare interventions. It's underpinned by health promotion and behavioural theoretical models, such as the health belief model, the theory of planned behaviour, or the socio-ecological model. And really it's targeting all three levels of the patient encounter and the factors that impact vaccine uptake at all of those levels. So it's really about developing a multi-component intervention with interventions at the practice level, at that provider communication training level, and then at the patient level where they're really seeking more education and information. So that's exactly what we've done, is we've developed this multi-component package that Jess is going to outline for you. And as I've said, we've really targeted at midwives in the public antenatal setting, and it's been informed by a qualitative study, which Jess will talk about, that's been led by Jess and Katie Atwell. We're piloting the intervention at the moment at the Royal Women's Hospital in Victoria, and that data will inform an NHMRC clinical trial application in May that we hope will fund a large multi-site cluster randomised clinical trial that I'll talk about a little bit further in a minute. But I'll just hand over to Jess to talk more about the intervention.
Thanks very much, Margie. So as Margie said, the first stage of our research was a qualitative study. At this point, we wanted to speak specifically with midwives in two different settings in order to get a better sense of what their practice looks like, what they need, what they know, how they feel about vaccination, and sort of how it fits into their current clinical role. And so we targeted two different settings. So the Royal Women's Hospital, as Margie said, which does not deliver the maternal vaccines on site. So at the women's, the midwives talk about vaccination, but they then tell the women to go, seek vaccination either at a council session or more frequently at their GP. And then at King Edward Memorial Hospital in Perth, where they do deliver vaccines on site. Some midwives are immunization trained, and they also have one immunization-only midwife who works most shifts, so she delivers quite a lot of the vaccines. So that was the primary piece, and then we analyzed those interviews, which I'll talk about in a second, and then we designed some prototype intervention components, and we presented them back to two different focus groups of midwives, again at the same hospitals, to discuss them more specifically in terms of features, design, appropriateness, and usefulness. And so some of the key findings from MidVaxCom were that the midwives that we spoke to felt that vaccination was a part of their role, whether or not they delivered it, but they acknowledged that they have a lot to cover in those sessions. They have to get through quite a lot of information, and there's a lot of competing priorities. So sometimes talking about vaccination isn't the highest priority. We found that the individuals' roles and the types of discussions they have may vary depending on whether they can deliver the vaccines there. So at King Edward's, where they maybe could refer someone down to speak specifically with the immunization midwife, it could mean that they didn't have as long a conversation. But then again, because the vaccine was on site, some of the midwives there felt that it was more, they were more confident in talking about it. And in some cases, the conversations were actually longer there. Everyone pretty much agreed that they receive in their midwifery education, undergraduate and training, very little specific training and about vaccination. So they didn't necessarily feel particularly confident answering really detailed questions about vaccination. While all of the midwives that we spoke to were comfortable making a recommendation to vaccinate, they spoke a lot of, we asked them a lot of questions around the phrasing of that and what they felt most comfortable with. And the most common way that this was phrased was sort of a more passive voice. So it is recommended, or the hospital recommends. It was much rarer that someone felt that it was their role to say, I personally recommend. And I think that that aligns with what we know about the midwifery model of care, which is very much around woman-centered care and informed choice. As I said, while they make this recommendation, they're not always confident answering extended questions about vaccination. The relationship between a midwife and a woman is paramount to the midwife role, but most midwives did say that they would press very gently to ask a reason for hesitancy if someone said, no, I don't want it, in case they could provide some sort of easy information that would change someone's mind. They all said that it would be great to have trustworthy online information that was more detailed than some of the materials that they currently have access to, and fact sheets are useful and valued in those consultations. They very rarely said that they discussed infant or later childhood vaccines. At the Royal Women's Hospital, even birth hepatitis B isn't discussed very much in pregnancy, and in fact, they kind of get consent for it when you arrive to deliver. So certainly that element could be increased, I think. Midwives said that in terms of what they would be interested in learning more about, they'd like to know those sort of key vaccine facts, so they felt more confident in answering those questions. And they were also interested in communication techniques around debunking myths, or how you deal with someone who has a misperception about vaccines. And it's just, we didn't have a massive sample size for this study, but the findings that we found do echo those that have been found in other Australian studies, particularly a study just recently published by Jane Frawley, which interviewed midwives and found many of these same issues. So from that, we designed an intervention package, as Margie said, with components at each of these levels. So the practice level components that we put together were vaccine champions. And in practice, what that looks like is it's someone, possibly the clinic manager or the head of the midwifery department, who takes on board the tasks associated with distributing the materials for this intervention and promoting vaccination among their staff. We also designed sticker reminders for the midwives to use to discuss or to record delivering of vaccines. So I've brought around some props. So this is what the stickers look like. There's a blue one that says flu, and it says discussed tick and date, received tick and date, or declined tick. And so that was something that we designed specifically based on what the Women's Hospital uses, which is paper VMR, Victorian maternity records. At hospitals where they use EMR reminders, that would be something that we would look at integrating into that system as an electronic reminder or prompt. And then also vaccine promotional materials for the clinic to remind pregnant women about the vaccines. At the provider level, we developed a 40-minute online vaccine and communication tutorial for midwives called VaxChat Australia. Now, this is adapted from tutorial used in America, developed in America as a part of that P3 study that Margie showed you earlier, which was developed for obstetricians in America. So a very different context. We adapted all of the language and the content based on what we spoke to women about in the to midwives about in the interviews. We actually, moving forward, are going to make some changes to that because we have found that 40 minutes is a bit long. So we're going to make some further changes before we get to the point where we trial this intervention. We also developed standardized written talking points where the midwives, after they watch the video, they go in to an exercise and create a cheat sheet. I just realized that I'm going to show all of these on the slides in a minute, but I'm describing them right now, so I'll click through those quickly. And then a provider portal with for the website that has a lot of information and fact sheets about the vaccines, and also links out to Sky. And then the parent level components are text message reminders for pregnant women, as well as the parent facing portal. And since I was going so quickly, this is what the stickers look like. They would attach, as I said, to the VMR. These are some screenshots from VaxChat. Of course, we had Margie doing an intro, and then it goes into, it's broken into 3 sections. So it focuses on structure of message delivery, content, so how you recommend or what you sort of say, and information about the vaccines, and then a little section at the end on making vaccination routine in the clinic. And I just wanted to highlight that the key steps that are highlighted in this video for provider communication training are really based on motivational interviewing and some of the techniques that are used by Sky, and some of the techniques, again, that are used in this original VaxChat video in America. And they involve making a clear recommendation to vaccinate using the language that the midwives feel comfortable with, eliciting concerns, and then some information about strategies to correct myths, asking permission to share information and sort of building that, which is already sort of part of the midwifery model of care, and then reminding the midwives to pivot back to the severity of the disease, which resonates more than statistics, and the importance of remembering 1 to 2 key facts about vaccines. So that's where this cheat sheet comes in. So as I said, after the video, they would go here, they'd fill in, they would select some key facts that resonated most with them. It would send them this little cheat sheet, which is small enough to print out, cut, fold, and stick into a lanyard badge. And so then if they needed to have a quick fact on hand, they could theoretically have it hanging around their necks. And then this is what the website looks like. So this website, as I said, there's a provider portal and a parent portal. They look quite similar, but have slightly different information on them. For parents, if they come into it, they can select which trimester of pregnancy they're in, and that will show them whether, the flu vaccine earlier in pregnancy and the pertussis vaccine later, and infographics. And then with the text messages, we based this work on a lot of work done by Melissa Stockwell and Annette Reagan, starting with the message about disease severity, moving on to a message of self-efficacy, where to get the vaccine. These are sent after the booking visit. Women get, a week after the booking visit, they get the flu reminder, and a week after the 28-week visit, they get the pertussis reminder. And then we've also got fact sheets that are printable or to give to parents, or they can look at them online. I've brought some examples of those if anyone wants to see them in person. And as I said, this all links out to Sky, so talking about immunizations, which was the subject of the presentation last month. So if people want to look for more information about the childhood vaccines, the midwives don't have to be experts in that area. And I will just switch back over to Margie to finish off.
Thanks. All right, we haven't got long, so I'll just whiz through these last little slides. So essentially, the intervention package is really being designed to fit and align with midwife values. We were very cognizant of not adding to midwifery, to their workload, but actually trying to make their vaccine conversations with pregnant women more efficient, and really trying to capitalise on this notion of embedding vaccine discussions as a routine part of antenatal care. And also, I think most importantly, creating a platform for the introduction of the new antenatal vaccines that are in the pipeline, when we're going to be trying to convince pregnant women to have 4 vaccines in pregnancy. And I think that's when, using structural levers and prompts and standing orders is not going to be enough. These women are going to be asking questions. They're going to be wanting to know more information about safety and effectiveness. And I think it's going to be very overwhelming for providers. But of course, this does all need to operate in combination with structural levers. So very briefly, I won't spend much time going over the pilot. Essentially, this has been running since October last year. It's very much about looking at feasibility and acceptability of this package. Clearly, there's a lot of components to the intervention. We wanted to know, can it be integrated into practice? Will the midwives watch the VaxChat video? What do the parents think of the resources? Are they useful? And we're getting all that data now. And all I can say is we've enrolled 25 midwives, 62 women, and it's all looking very promising so far. So in terms of just some quick quotes and things from the midwives, essentially they have been very receptive to the VaxChat online communication training video. They found it very helpful to have more facts to be able to use in their discussions with parents. That the midwives have liked the stickers as prompts to have these conversations and to record the vaccines. And overall, I think what we're talking about here is just building their confidence in discussing vaccination with pregnant women and having those key vaccine safety and effectiveness facts at their fingertips. So in terms of the next steps, this is the trial I mentioned at the start. I did forget to say earlier that the trial that's been run in the US by SARD-OMA is a large NIH-funded trial that's been run in Georgia and Colorado. And the data from that trial, that's targeted to obstetricians in private practice. The data from that trial should come out in the next 3 to 4 months. It is a similar structure to this trial, but obviously configured very differently and for the US setting. So in terms of our proposed trial objectives, our primary uptake and what this trial is powered on is maternal influenza vaccine uptake, but we're obviously looking at pertussis uptake and then the uptake of the childhood vaccines to 7 months of age, so a month after they were due at 6 months. We're looking at the impact on maternal and childhood vaccine knowledge and attitudes, degree of vaccine hesitancy and intention to vaccinate their infant, and then of course on the provider self-efficacy in communicating about vaccination. And then we're going to look at the ease of implementation and identification of the key factors about how this could actually be scaled up. Because ideally, we'd love to see this introduced in most public antenatal clinics around Australia as a package with the support at all those 3 levels to really move antenatal vaccination uptake forward. Those are all the references, and I think people might have access to this later if they want to look at some of those references for the data that we've quoted today. But most importantly, there are a huge number of people to thank as part of the teams that have been involved in the development of this study, particularly Jess, Katie Atwell and SARD-OMA, but also very specifically Julie and Annette Reagan, Kerry Wiley, Yvonne Hoak in WA, and Jacinta O'Sullivan, who's been leading the pilot in Victoria, and many other people in the family. So thank you very much for listening, and we'd love to take some questions from you.
Great, thanks Margie and Jess. Some great presentations again. We've only got 2 minutes, 2 minutes left for the online audience. So do we have any key questions?
I'll sort of put them together. One is about access to some of the resources outside of the study environment. Can it be particularly registered nurses? And then your idea about taking it forward with different levels of health literacy and English as a second language.
Thank you. Those are both excellent questions. Firstly, we think we are most likely going to make the website and the resources available before the end of the trial, because obviously we really do want to get these resources out there and being able to be used. What we're going to be evaluating in the trial is the combination of all of those elements in terms of maximally increasing antenatal vaccine uptake specifically. So we are going to be working, I think, and particularly with Christine, about trying to have these resources available and linked with NCIRS and with Sky, of course. And yes, it's an excellent question about translating the resources into other languages. We will be looking at that, and we're actually currently seeking other funding to be able to translate the materials.
Okay, we might say goodbye to our online audience now. So hope you got something out of both of those sessions. They were both great. Yeah. Bye. Bye.